back to our positive behavior. It always pop up whether you continue because it's recording. Yeah, again, thank you everyone and welcome for coming back to our positive behavioral interventions and supports echo series. And we have this monthly series going on and we will continue. So thank you for keep coming back. And I already see some familiar names in the chat. And also see our case presenter today, Donna. So hi. So we will try to mute everyone at the beginning, but if you have questions, especially you can feel free to chat in. And also when we have a case presentation, please feel free to unmute yourself to join in the discussion and ask questions. Because ECHO is really a online learning community that really everyone participation is greatly appreciated. So we would encourage you to keep your cameras on if you can, but we totally understand if you're not in the environment that is doable. Also, because we have this entire ECHO series and we appreciate everyone's attendance and participation, we will be able to create a completion certificate at the end of the entire series that lists all the hours you have participated. So if you have already put in your name and email address when you log in through Zoom, that's great. But if you happen to join in through phone or other ways that you were not able to do so, it would be great if you can change your name to your first name and last name so we can make sure that your names are included in the certification of completion. Next. Next slide, please. Thank you, Eve-Lynn. So it'll be great. So we're gonna do a really short introduction of the people who are here. In the meantime, it'll be great if you can chat in your name and the organization you are affiliated in the chat box. You can tell us what you mostly want to get out of this learning session from your participation today. So I will just say quickly my name is Alice John, and my background is in behavioral analysis. I'm a board certified behavioral analyst at the doctoral level, and I'm a faculty member here at the occupational therapy department at KU Medical Center. And Linda?
My name is Linda Heisman-Powell. I also am a board certified behavior analyst at the doctorate level. I'm also a licensed psychologist. And I work with Alice and Eve-Lynn actually on using telehealth to be able to get services to underserved areas.
Yes, Eve-Lynn, Dr. Nelson, please.
Yeah, good afternoon. Nice to see folks on the screen. I'm a psychologist in our behavioral pediatrics department, and then I lead several initiatives around child telebehavioral health. I was going to say, I think Alice, Dr. Zhang, there may be a couple minute delay as I advance the slides, so just letting you know.
Okay, yeah, no worries. Yeah, thank you for all chatting in. Dinah wants to get some tips for her middle school students in the PBS classroom. Yeah, this is a big topic because we are going to focus on more the middle school age children, adolescents, and also Dr. Nelson has extensive experience working with adolescents. So you're at the right place. And thank you, Polly, for participating in our multiple sessions. Thank you, Polly. Okay, next slide, please. Thank you, Lindsay, for care coordinator for autism and SDED waiver. That's such an important job since we work with a lot of families of children with ASD, and they need a lot of support, and appreciate your work. So for the agenda today, so we're going to have a quick introduction. We already did, and we will have a didactic presentation that Dr. Nelson will present. Also, we will have a case presentation thanks to Donna, who is going to share a case with us and have some discussion. So we really appreciate you. We will have Dr. Nelson, Dr. Heisman-Powell, and myself asking some follow-up questions, but also welcome questions from the audience as well, because again, this is an online community. Your participation is equally important as our participation. Also, we will try to, Dr. Nelson will try to do and I will try to do a summary of recommendations, and we will be able to email this summary of recommendations back to our presenter. So just a heads up, we also have other sessions that will be going on for the rest of the month until November. So if you are interested in participating as a case presenter, please email us, and we will also send out an email, and so there's a link you can participate. Next slide. Oh, one thing is that we have a thank you, Dr. Nelson. We have a level up sign here. So if you see this sign, we really want to hear from you. So please type in the chat box how you would apply the concepts in your setting. We would love to have some great discussions going on in the chat. Next slide, please. Okay, so assessment. So since you have been already in this session, though, you have already received some kind of survey from us. So we appreciate you completing those. In the meantime, we will send you a post-training survey as well, and it's really a short survey. I think it has 9 questions at the most. Should be really quick to complete, but it's really helpful because this ECHO series was possible because of the support of the Cigna grants. So the funder really want us to give them some data back to show we actually made some positive change in the community. So appreciate your help in advance. Next slide. Okay, the last thing is the case presentation. So as part of the Cigna grant, we are also providing one-on-one case consultation for our, I think this is the slide. So, so if you have a case, you obviously are welcome to present in ECHO series, but in the meantime, you are also welcome to email us and let us know if you want to schedule one-on-one meeting with our experts here. Thank you. Next slide. Okay, so we do not have, I will leave this slide to Dr. Nelson since this is related to the content. I will turn it over to Dr. Nelson for the diegetics.
Super, thanks so much. Just a reminder, we're presenting the best information at the time. We live in a fortunate time where there are new interventions and treatments that are being developed for depression in adolescents and broader children. So just to know that we're presenting the best we know at this point in time, but always, on the lookout for some of the new and evolving research. So today's objectives, I really hope to build on Dr. Osmeyer's comprehensive presentation about depression. I hope several of y'all were able to attend, and would really encourage looking back at her presentation if you weren't. It really has some fantastic, just practical tips about supporting children in general with depression. I'm going to talk some about how to recognize depression and its effects, as well as some of the mimics of depression and co-occurring disorders. And then finally, I'm going to talk some about psychotherapy treatments for depression. I'm going to focus on cognitive behavioral interventions, which are efficacious and widely used for depression in adolescents. But again, I think that paired with some of what Dr. Osmeyer presented about behavioral interventions is really some of the strongest treatments that we have. This is my reminder story, slide that any of us can be affected with depression. Depression cuts across age, it cuts across famous singers, famous athletes, everyday folks, I live with 2 teenagers in my own household, so also having that with them and their friends. So it's just really kind of my own level up slide that anyone can be touched by depression. We'll see in a minute the pandemic and the stresses that have been overlaid in everyone's life with that also play into some of the risks for depression that we see in youth at this point in time. Before I get rolling, I also want to say it's kind of a heavy topic for a Monday, and it's such an important topic. The other message I want to send is that we really do have good treatments. If we connect with children and family early, and if we work as a community, we really have some good positive treatments that we can extend to youth and their families and help them through a difficult period of time. So just as kind of quickly going through some of the diagnosis of depression, remember it's at least a 2-week period of change in mood, and really keys are either a depressed mood or an irritable mood, especially with teens. They're snarky, they're not comfortable, they don't feel good, and that can be conveyed in the mood. Other symptoms that we really look at is the change in appetite, too much or too little, the change in weight, changes in sleep, challenges with concentration and indecisiveness, just really having trouble making a decision, changes in energy, that can be revved up too fast, or it can be really sluggish and having challenges. Just kind of taking the pen from beginning of paper to end is very hard. And changes in self-esteem, changes in motivation, and then most concerning, of course, is some of the recurrent suicidal ideation and just really being on the lookout for any safety concerns and directing to immediate services as if that's indicated. The symptoms represent a change from prior functioning and are impairing the child's life, and then they're not solely attributable to substance abuse, medication, other psychiatric illness, bereavement, or medical illness. Of course, all those are things we want to support, whether it meets the full definition of depression or not. If you're seeing this pattern, something's going on, and often the child and family are in need of some level of support. Just to kind of give you a picture of the epidemiology of depression. So we do see over the course of the lifespan, the prevalence rises, continues to rise through the teen years, and by adulthood, about 17% of the adult population will have a depressive episode. It's of course more common in primary care settings. And then in terms of male-female ratio, in kids, it's more 1-to-1. As we hit adolescence and into adulthood, more females are at risk of depression at a rate of about twice the rate. I think this is really important epidemiological information because it's speaking to the incidence of depression, but also just the average length of an episode is 9 months. So when you're thinking about children and youth, that's a really big developmental hit. That's a long period of time to struggle. 40% are at risk for another episode within 2 years, 72% have another episode within 5 years. And then among adult patients with depression, half or more report having their first episode by age 20. So this all is speaking to early intervention and early identification of depression. In terms of morbidity and mortality, again, I think I'm singing to the choir a bit on this one. Just keeping in mind, depression has a hit on almost every aspect of the young person's life, their health and development across emotional, cognitive, and academic and social skills. Left untreated, we really see that impact ripple out long term, impacting quality of life, educational attainment, employment, work performance, marriage and family relationships, and other risk behaviors. And then, of course, we're always concerned with depression and depressive symptoms, just really being on the lookout for suicide with approximately 60% of youth with depression reporting having thought about suicide and about a third having attempt. And just to say that our Kansas population really matches up with those statistics. We are seeing an increase over time of suicidal behaviors with our youth, so that's concerning in general. And again, we need to be on the lookout in Kansas because we're really tracking pretty close to what we see nationally. This is just a reminder slide. If you have concerns about suicide and safety, of course, looking at your own organization's crisis reporting plan and resources. And these are some other resources that we have both nationally and in Kansas. This is my reminder slide. Kind of sometimes when you have an adolescent presenting with depression, they may present that, oh, if I just hadn't broken up with my girlfriend or boyfriend, or oh, if I could have just made an A on that test, or if you know, I hadn't tripped and then been made fun of and laughed at, everything would be okay. This is kind of a reminder slide to keep in mind that depression really is a whole health body change. Those events sure can influence and kind of set off a depression, but we're really looking at this biopsychosocial multifactorial model when we're thinking about depression. Kind of our family experiences, genetics does play a role, especially in the mood disorders. And you know, having those risk factors if others in the family have depression and anxiety. Looking at the cognitive representation, so really having a negative view of self, world, and others is what we see develop with depression. Not feeling that there's a sense of interpersonal competence or having those ways to interact with others. Lay on that life stress, which we've seen in big dose of life stress with the pandemic, and then kind of the ultimate endpoint is depression. There may be different pathways that lead to that endpoint, but just recognizing it's kind of that set of factors. In ways, this is good because it also gives us different points and different strategies to help the person who's experiencing depression. This is just a reminder slide of some of the overlap with depression. As a health psychologist, you know, we really want to think through, you know, it may be depression and other things, or it may be some other things that can mimic depression that we need to keep in mind. We're always kind of thinking, is this depression the first of a set off of a bipolar disorder? So, you know, with the adolescent group, also being on the lookout for any kind of, you know, quick mood shifts and the other characteristics of bipolar disorder. Just recalling that there's a huge overlap between internalizing disorders, so anxiety and depression. And then also, I think what sometimes is surprising to folks is there's also a really big overlap between externalizing disorders, so ADHD, disruptive behavioral disorders, all of those also have a strong overlap with depression. And we really do see that as youth, especially come into adolescence. Being mindful of substance use disorder, which can both present with mood disturbances and depression, or it may be co-occurring with some of the depression. And then we heard really well from Dr. Osmeyer, just really the idea of as folks isolate and they lose some of their connection to their psychosocial environment, really the downward spiral and loss of some of the competencies that really is difficult with depression. Keeping in mind that depression is common with medical conditions. That's why you'll see in just a moment, we always want to encourage folks to also be seen by their primary care doctor as well as their behavioral health team, just to really see, is there other health factors that are influencing the depression. Also remembering that some of the medications, including some of the medication used to treat psychiatric conditions, can also impact mood and cognition and psychomotor activity, some of the things we're looking for in diagnosing depression. So kind of just, again, figuring that into diagnosis and treatment. This is a slide, more the take home with this is not to remember every co-occurring physical illness that can go along with depression, but just really having that picture in mind that about every body system can have symptoms that result in change in mood, and just the importance that primary care is weighed in, that the child and youth, you know, are they suffering from some co-occurring physical concerns that may be influencing what you're seeing in your clinic or in your school when you're working with a student or child with depressive symptoms. This is a reminder slide, just keeping in mind that grief and depression, of course, very important. The two can go together, but aren't exactly the same thing. So remember, with grief, of course, we're really looking for a trigger, identifiable loss. And again, important to have lots of supports for the child and family with grief. The grief is not so much a diagnosis. Sometimes a grief for some can lead into a depression, or it can be one of those factors we saw in the model that can tip off a depression. So I like to think about this as level of stuckness. Like, are you seeing kind of with supports and over time, the child and youth is kind of you know, being able to function? Or with depression, are you seeing that they're really stuck and they're not being able to function and engage in the important activities? And then there's always a social context. We've already touched upon this, but just remember that, you know, we're always figuring in the social determinants of health, the parent and caregiver's own behavioral health concerns. Violence and abuse can really impact depressive symptoms that you're seeing. Major life changes, which could be really good life changes, or it could be challenging ones. Just the idea that change is difficult, and youth with some depression, anxiety, you know, that it's possible that could tip off a depression. Looking at really too much or too little. So too little activity, or really the overscheduled child that, you know, they're just going from one thing to the next and never have a second to breathe. Sometimes that can go along with depression. And then we've talked about grief. Just in terms of looking at assessing depression, this is really one that we hear so much from families, like, oh, you know, I don't feel good. Why do I have to answer all these questions and meet with several folks? And I think it's good that we have ready the why. Just as we've seen, there's so many factors that can play into depression. So just thinking through, that's why we have you fill out these forms and have you talk with us for an hour or whatever time period. We really want to get the best picture and around the multiple things going on, so we can give you the strongest possible treatment. I'm going to pause there a second. I'm kind of shifting from talking about some of the assessment into some of the treatment. And I just want to take a moment to see if there's any questions of the things that we've talked about so far.
I have a question, Eve-Lynn. If we're working in a child-facing environment, but it's not a clinical environment, what are some of the things that, you know, you did a really good job talking about and you might get to this, You did a really good job talking about that it's a change from a previous state, but what are some of the key indicators that would trigger us to talk to the child's parents?
Sure, that's an awesome question. I think, especially schools who've seen the child over time can be really helpful at that. I think when we're talking about change, a kid that where academics was a piece of cake before, but now it's just so hard for them to start an assignment, or they're just, you're hearing in class them say negative statements like, oh, I'm such a dummy, I can't do this, or whatever the negative comment may be. If that's, I think, can be really helpful from outside folks who have that picture of the child over time. And I think, if you're talking with the parent or guardian in that point, really sticking to what you've seen. It's not saying, I think this is, you don't have to diagnose and say, oh, I think this is depression, because sometimes I think that's challenging, and getting all those pieces together, it's hard to immediately kind of jump there. But I just think saying, I'm concerned about your child, I've seen this change, what are you seeing? And just kind of describing the change that's been seen. I think too, changes like, your child seems so tired when they're coming in. I see them falling asleep, whether that be at school or other places. I worry about them. I don't know if others have ways that they've addressed that, or kind of sharing concerns about a child who may have depression or anxiety symptoms.
There's a question in the chat, Eve-Lynn.
Yeah.
What do you feel are the main attributes to the rise, or what contributes to the rise in mental health in teens? They're wondering if there's any research related to increase in technology, access to technology, probably social media.
Sure, that's an awesome question. So there is some research along those lines, both for youth and adults. I think the one that really jumps to mind is some of the impact of being on technology all the time. It impacts on sleep and social engagement and some of those factors. About 5 years ago, it was kind of in the press and some of the behavioral health about, they were labeling it Facebook depression. That's not a clinical term, of course, but just that idea about social media sites and the impact on depression. And I think that can really figure into stuckness. Like if you see someone who's only kind of narrowing their world to engage with social media, and then there's a lot of discussion with that about self-comparison and really getting skewed views of what others in the world are like. And of course, the pandemic's been hard on that, because you don't really have in your environment sometimes just some comparison with just folks in your community and folks in your own school. So that doesn't, I'm not sure that answers the question, but I think it leads to a good set of questions as we're talking with children and families about, what are you doing besides technology? Maybe it's starting small, just something really small that's separate from technology. But I do think getting stuck in technology, of course, is a real challenge and is likely contributing to some of the depression that we see. I'm going to jump a little bit. I want to make sure we touch base on some of the treatment. So again, I think the behavioral treatments are super important, as is some of the medication management that we see, especially with moderate and severe depression, as really important. I'm going to focus on what I know, which is the cognitive behavioral therapy part. So that's what I'm going to focus a little bit of our time on. It really built on these three assumptions. that kind of, we see the symptoms of depression and anxiety maintained by some of the learning and information processing that the youth is doing. Change occurs as we practice, and really practice is key, and it's hard for adults, it's hard for kids. So practicing some more adaptive ways of looking at things. And then the focus of change is really looking at thoughts and behaviors, and looking at, by practicing more adaptive thoughts and pushing ourselves on some of the adaptive behaviors, it can ultimately support some of the changes in mood. I imagine most of the folks on the call today have seen this triad where we're looking at cognitive behavioral therapy. CBT is really always looking at situation, what's going on? Tell me about what's going on, what's running through your head. I like to use the thought bubbles. You know, I think that's a fun thing to do with kids, and kind of what's in your head, looking at behaviors. And so this is what you thought, and this is what your behavior was. And then also looking at, you know, how are you feeling at that time? How is that influencing how you're feeling? Did it make you feel better, worse, or the same? I think that sounds real easy, but it's not. So I know I'm not spending a lot of time talking about it in this overview today, but it really takes a lot of practice when you're really stuck and your biochemistry is also stuck, to really practice the things that can help kind of move from that depressive thinking to non-depressive. I think it's really important to share a rationale for treatment. We'll see in a handout in just a minute about talking through what is depression, demystifying what that is. That's really important also to decrease blame, really talking about, we do have good treatments, we can work on this together. It's going to take some time, but I know that if we work together, we can see changes, and we can work together to help you feel better. This is just an example of a patient handout, pretty straightforward. This is for a little younger child, but I think it's helpful, just kind of really prompting with that youth, you know, what are you feeling? Like, what words are you using? Talking about how depression affects how you feel, think, and behave. Talking about it's not your fault. It's a health issue. It's a medical illness. It's not a weakness, a punishment, or something wrong with you. And then really emphasizing it's also treatable together. In terms of treating the behaviors, you know, we're often looking for really, how do you schedule in pleasant activities? And I think the smaller, the better. I think what we see with children that are youth or depressed, it's very hard to generate a list such as this of things that they do enjoy. So if 15 minutes of doing something you used to find enjoyable is too much, let's pare that down to 10 minutes or just 5 minutes. It's just that idea of very slowly kind of re-engaging with family. You know, maybe it's around structured activities at first, like it's watching a movie, or, you know, something that isn't as much of a load to lift, and then eventually looking at more of the social interactions and other things that the child used to enjoy. But this is very hard, and so if you all have any things that you've used to really help engage in those kinds of positive activities, it'd be great to hear from you. Also looking at treatment, looking at problems with emotions. Partly it's practice in labeling emotions, looking at the range of intensity of emotions. So kind of making it more, well, you can have a range from irritated to angry to furious, but not every time furious. And that takes a lot of practice to kind of recognize some of those earlier signposts that the person may be building to more extreme emotional, intense reaction. And then work linking thoughts, feelings, and behaviors. And looking at problems with thoughts, it's a lot of monitoring self-talk, which again takes an awful lot of practice. Kind of things like your inner critic, or, you know, kids can often come up with what they call that voice in their head. And really practicing challenging negative self-talk and looking at more adaptive ways to look at it. You'll hear that with youth and children, we're not really saying irrational. It's really a focus in on what could you say that makes you feel better instead of worse? What's a more positive way to look at that? And then as you get into teen years, like looking at what's the evidence for the negative perception. Again, that takes a lot of practice, and you would do that hand in hand with the parent guardian and with the person who's helping support CBT.
We have a chat from Hannah. She said, I used to work with mainly teens, and involvement in community improvement really helped them throughout the pandemic. I think that was to your level up question box.
Oh, I think that's an excellent point. It's kind of that idea I can be part of something bigger and have a positive impact. I think that that's awesome. I think generationally too, we really see Gen Z and some of the youth coming up really find that meaningful and engaging. So thanks, Hannah. That's a great point. This is just another way kind of to describe kind of more adaptive thinking. This one's for a little younger child. This would be more kind of our you know, CBT go-to with trying to look at situation, feeling, thought, and behavior. We're fortunate there's some things like this now and apps. So really trying to join the kid where they're at with some of this this work. I give you a couple of thoughts just on, you know, the kinds of questions that you would look for. Again, this is down the line in treating depression after you've kind of re-engaged in positive behaviors and you have that relationship to work with the child on kind of looking at what's the evidence for your negative thought and how else might you look at it. We touched upon this, I think, with the earlier question, just also addressing problems with physiology. So really getting back on schedule with eating and sleeping, reestablishing overall good health behaviors, all that can really help with depression. You know, I get the question sometimes, well, is there any one nutrition thing that can change? You know, overall nutrition is really important for youth. So there's not one thing linked with depression, but just an overall good health. You know, it's good for child, it's good for family. So that tends to be the recommendation. And then also some of the relaxation training. It's just so often that you see anxiety and depression going hand in hand, that the relaxation training can be really important. And it's something quick that if you practice and get good at deep breathing or muscle relaxation, it's something that can help kind of slow down enough to kind of think through what is the thought and how can I perhaps look at it more adaptively. Problems with relationships. So again, this is kind of all about all working in partnership. The child really may have lost some social skills during the depressive episode. So, you know, thinking about small ways to help reinforce and develop those skills and support the child with those skills. I wanted to mention related strategies, just as the child may also have medication management. There's lots of adaptive things you can help with adherence monitoring and supporting. And then I think, you know, as the child is feeling better and is engaging and functioning, that's wonderful, but also talking about how depression is a chronic illness. We would expect there's times that are better and times that are worse. So my door's always open. I'd love to talk with you. If you're hitting a rough patch, would love to see you sooner than later. You know, just kind of making that normalized so that it's not a self-blame if some of the symptoms of depression reoccur. And with that comes some booster sessions. So I had a level up on this slide. I think I went through some of the treatment ideas fairly quickly, but it's really just to kind of give you an overview. These strategies, I think, are all pretty straightforward and they make sense on their face valid. But I do know it's just so hard when the child is stuck. It really is helpful to hear some similar positive messages across, you know, be it therapy or school or community and other child serving systems that are supporting the young person. This is just a few resources. They'll be in your slides. I really like Breathe to Relax, and my teenagers like that one too. So I included a couple pics of that. And then around more youth suicide prevention, we had a wonderful presentation by Meg Fowler with a previous echo. So some of those resources I think are helpful as well. So I think kind of in terms of leveling up, we want to make sure there's time for the case. So I know I went fairly quickly through those last ones. We'd love for you to share in the chat any key takeaways from today, any skills that you may apply in your practice, and anything that you might share with a colleague. So feel free to chat that in or to unmute.
Yeah, we have maybe a couple minutes if you have anything that you want to share with us.
I had a question. I was looking at some of those on the previous slides, like you were using kind of the questionnaire of like, you know, what they did today, was that helpful? And even that slide before this one, like for the teens and even for the smaller children, like, will those be able to us to like have? I think those would be like really good for to use like in our practice.
Oh, like Breathe to Relax?
Actually, it was kind of before that. It was a I'm sorry, it's Monday morning. Okay.
Oh, no worries. Was it?
Oh, so okay. So like that one that kind of monitored the medicine,
sure.
and then that thoughts and feeling ones that had that one, and the one for the younger. Yeah.
Yeah, absolutely.
So those things.
The other thing I'll mention, we're glad to send those out. I think when we have the follow-up, the GLAD PC toolkit, it was developed for primary care, but there's a lot of handouts in that toolkit that I think are useful. I believe that's where the side effect checklist is from.
Okay.
If others have ones they love, it'd be great to kind of hear, or please feel free to share those.
Yeah, thank you, Donna, for that great question about resources. We will definitely share the PowerPoints and also the resources that have been shared in the chat as well. So if you have any resources that you used and you really like, please feel free to just put in the chat, or you can just email us later as well. We can share with the larger group.
Yeah, I think that would be great, because some of the stuff that you had in there, Eve-Lynn, I think were good, like the reframing slide that you had, because for those that work in early childhood that are not necessarily a clinic service, I think that's just good practice all around, right? Is to, like, if the teaching social emotional responsibility, if the kid says, I'm so dumb, I can't do this, you know, to reframe it, to say, oh, you made a mistake this time. You know, you're pretty good at this. So what do we need to do so you can be good at, you know, writing your letters as well, you know, or something along those lines. Just learning how to take some of what our kids say and reframing it. So I really like that as a really good strategy to be able to use just across the board, right? Whether it's with kids that we think are experiencing depression, or just having difficulty with social emotional regulation. So thank you. That was a great slide.
Thank you. And I think, I think along with that is using it ourselves. Like a lot of these, I think, driving and you get cut off and it's like you have those angry thoughts. I know I talk to myself in the car too and think, okay, it's probably just someone who didn't see me, or I think the more we practice these, it's easier to teach and help others practice.
That is such a great point. So we need to practice our own to preach to the children of others, and also it's those good strategies are helpful no matter whether you have a diagnosis or not.
Sure.
Yeah, Eve-Lynn shared a really good point about a progressive muscle relaxation and CBT, even using audiology. So that's great.
Fantastic.